firm, it's thicker, it's fibrous, doesn't absorb, right? That makes sense? Okay. So the replacement of that, and a lot of times you'll send patients for liver ultrasound. They'll come back and say that they have a hard liver, or you can actually palpate their liver when you do your exam. I'm working on mine. Liver is a very dynamic organ. This is a little background about livers. Livers are very dynamic. You know, you can actually take a lobe off the liver and it'll regrow it. It's one of the only regenerating organs we have in our body. And the liver, every time you have a Super Bowl party, you break a little of your liver down. And then it, kind of redoes itself. That's why alcoholism is one of the major causes of liver problems. And topic at hand, cirrhosis. Because of the constant breakdown and then replacing the scar tissue. Okay? Cirrhosis can lead to liver failure, but is not the only cause. Other causes that we know about are infectious agents, toxins. What kind of toxins?
Drugs.
It can be chemicals. It can be acetaminophen. And acetaminophen is an awesome liver killer. Did you not know that? It's right out there on the grocery store shelves. All the acetaminophen you need to kill yourself with is right there in your local Walmart, Walgreens, Fred's, Dollar General, or wherever. I'm a fan of Dollar General. It's my favorite store. If you're bored on a Saturday afternoon, go to Dollar General. I don't know where those people come from. It's like a social experiment in there. It's awesome. It's the same people that show up when the tornado sirens go off. Anoxia is another problem that can cause cirrhosis. Malnutrition. So there's a lot of different things to do it. But of course the number one cause is alcohol. I'm going to talk about these signs, these increasing symptoms, kind of as they go across your map there. When you go across to what would be your left, and then it goes down and it starts with jaundice. Kind of start those in increasing symptoms. So jaundice is really one of the first things you kind of see, right? Because liver clears bilirubin from the blood, and when it builds up, what happens? Well, you turn yellow like a road sign. And I'm literally saying like one of those curve signs. I've seen people come in that you can see them in the dark of night glowing. They look like the glowing sea monster off Scooby-Doo. They walk in and you're like, oh! Can't get hit by a car if I can see you. And it's not just in their eyes, but it's everywhere. But where, we see it a lot in the eyes first, don't we? How many of you's ever cared for somebody that's chronically abuses alcohol? You see those jaundice eyes, don't you? It's not hard to tell. So jaundice is an increase in bilirubin, serum bilirubin. Once we start seeing jaundice, some other signs and symptoms we'll see is anorexia. It kind of goes along with that heart failure thing, doesn't it? You get that liver involvement and you get anorexia, don't you? It's not the heart failure that causes anorexia. It's the liver involvement. Itching. Why itching? Those bile salts come to the skin. Bile salts will collect up on the skin. They cause lots of itching and rashes. But we don't lotion them, do we? No lotion. Dark urine. They'll be spilling stuff into their urine that there's not supposed to be there. Right? Urine bilirubin should always be 0, but in liver patients it's not. Clay-colored stools. Consistent clay-colored stools, not just one. I'm telling you this because don't, eat something for one time and go home and have an off-colored bowel movement and diagnose yourself with cirrhosis, okay? Know how y'all work. All right, some labs. And these labs you need to really be kind of familiar with, and these labs with the liver. And I don't think your book mentions a lot of them, so I'm going to throw some numbers out. You probably already have them, don't you? The direct or conjugated bilirubin. Y'all got these on the list? You need to review that handout, man. All right, but you need to look at what is the most important of liver enzymes? The ALT. ALT is the most important. It's really specific. The AST is kind of like when we talk about heart enzymes and the troponin. The troponin is the golden one, but you can also draw CKMBs. The CKMB can be an indicator, but it's not that specific. Well, AST is the same way. It's not that specific. AST can be caused by MIs, pancreatitis, burns, renal failure, a whole lot of different things. But ALT is just specific for inflammation of the liver. Okay? And I suggest that you be familiar with those numbers. If we take the time to give you a handout, it's probably a good idea. All right? Treatment is symptoms only. And we'll talk about some interventions and treatments that we do. Where we treat symptoms only. On down, you start talking about portal hypertension. This causes a myriad of different issues, doesn't it? With portal hypertension, we've already talked about it just a little bit. With portal hypertension, you have about 75% of the blood volume backing up. And again, here comes another analogy, and this is one that Mosby likes to use, and it makes sense. Say something catastrophic happened to I-630, which I-630 is a huge vein of traffic that runs through the middle of Little Rock. Well, when that becomes obstructed, what happens to traffic on the side roads? It increases almost to the point of those are obstructed, right? Yes. So when you have that portal hypertension, what blood seems to want to do is take the side roads around. Okay? And that's where we develop these other problems because these capillaries can't handle that volume.
Is that different than collateral flow?
No, not really. It's overdoing the collateral flow. Collateral flow is a wonderful thing to have because it branches off the main line and it's alternate routes. But when you oversaturate those alternate routes, the pressures are too great, they can't take it. So then blood tends to work around the liver when that occurs. And just think about the mechanism. We talked about liver tissue being replaced with scar tissue, right? Well, when that blood enters the liver, what's the liver's function? It really detoxes or acts like a filter to filter out stuff that, the waste and byproducts of metabolism that we don't want in there. And it really regulates that. When it's unable to saturate and take the volume of blood coming in, it backs up, doesn't it? It's the same symptoms as heart failure. When the heart can't take what comes in to deal with the volume either goes somewhere else or the fluid goes somewhere else, doesn't it? So with this shunting of blood around the liver, we have a couple of different issues that arise. One's ascites. And there's a couple of different things that happens with the ascites. It's not just the pressures building up, because that is part of it, right? But you also have decreased albumin production, don't you? So let's say, here's the god-awful drawing. There's a, what's a pointed liver, isn't it? All right, so here's the blood coming into the liver, right? Blood out. Well, we can't take the volume coming in here anymore, so we're having to send it around here, right? Therefore, pressures within the vasculature right here are so high because of the pressure and the inability to get that actual volume around that liver, that we start developing pressures that push fluid out to the vasculature, right? Subsequently, we have a decrease in albumin production, right? What is that? What is albumin to our body?
Protein.
Okay, I got that. What function does it have to do with fluid volumes? Yes, it's a magnet. It is a fluid magnet. Okay? So, if we have decreased albumin in here, then we have decreased what? Decreased fluid, because there's nothing holding it in, and the pressures easily push it out to the third space. Does that make sense?
Mm-hmm.
With livers, you can literally have hypovolemia and edema at the same time. Does that make sense? Because of these pressures, third space, and fluids, you can decrease blood circulating volume. Did that connect? But because of the pressures of the fluid going out, you have edema setting up, right? So with all this fluid stretching out around the liver and going out to the abdominal area, we have ascites. So what are you going to see on ascites?
Distension.
Distension. Big time distension. Have you ever seen it pronounced ascites?
Yeah.
Yes.
Where their belly button protrudes about that long? Where they have an outie that's about that long sticking out? It's amazing. It looks so painful. It has to be painful, right? It's got to be. What does having ascites and that much pressure in the abdomen do for you? What's it cause?
Shortness of breath.
Respiratory issues, right? Because all the pressure's going up. They obviously never listen. Squeaky wheel gets greased. All right. But all that pressure building up, pushing all that out, once you get that, then you get, the fluid goes somewhere. There's only X amount of space in here, right? Well, the more fluid we pour in there, the more it's got to take up room for something else. So it pushes those lungs up high, doesn't it? And it increases intrathoracic pressure. And it doesn't allow them for good expansion either, does it? So it sets themselves up for infection issues. So we're going to assess the abdominal girth daily and look at and see how much larger they're getting. We're going to weigh these patients, aren't we? So again, as with renal failure, daily weights comes in. It's very important. We're going to monitor their fluid and electrolytes closely. What else are we going to do for them? Anybody ever hung a banana bag? We're going to provide them big-time multivitamins, aren't we? For one, they're not getting the nutrition they need. Two, if they're alcoholics, they really need it anyway. Banana bags, you know, if you come in and you get a banana bag, you know what you've been doing. All right? It's full of B vitamins, thiamine. Good for you.
Is this the one that's the fat soluble vitamins that they get?
It's the big yellow bag. I don't know if they're all fat soluble. They're not.
Thiamine, folic acid,
No, those aren't fat solubles, I don't think.
You know, the lipids
Fat
are every-
solubles are E, A,
D,
yeah. All right, so we're gonna do thiamine, folic acid, multivitamin supplements. May need some magnesium. We're gonna position them comfortably so they can breathe maximum. May need O2 to supplement. Also with the ascites, we're going to watch them and put them on a low sodium diet. May need some diuretics to help with the buildup of fluid volume. May need paracentesis. What is paracentesis? Well, they drain. Somebody in clinical had a liver drain yesterday, didn't she? Not in this room. Somebody had one. They may even do, and I think somebody asked about this, TIPS procedure. All right. I did my research. That's really a liver bypass kind of sort of, where they bypass the liver with some of it. So they alleviate some of the ascites by building a new freeway, so to speak. Okay? All right, esophageal varices. The pressures get into that capillary bed in the esophagus, and they call these varicosities to form. Now, this is these things are bad. Varicose veins in the esophagus is not where you want to get them. You can have them in your legs all day long, and they're okay. But when you get them in the esophagus, they cause a particular amount of problems. Mainly because if one ruptures, it's hard to bandage it. And the esophagus is what? It's pretty vascular, isn't it? It's hugely vascular. This blood flow, this rerouting of traffic of blood through to the smaller vessels attacks these esophageal veins. And actually, if they have esophageal varices that rupture, 30 to 50% of them die right then. Over half. From my own personal experience, somebody came in with esophageal varices and they ruptured one. They were kind of toast. Especially in the smaller hospitals that don't have, balloon tamponades and interventionalists right there in the waiting surgeons ready to go, because it's not like you can get on the phone and dial out to a surgeon or an interventional radiologist and say, hey, we need you to come on in. They'll be there in 30 or 40 minutes. And by that time, you've run through your entire blood flow to supply at the hospital, and the patient's dead. That make sense? So, with esophageal varices, we worry about severe bleeding. And with severe bleeding, we have signs of hypovolemic shock, which are tachycardias. Because remember what we talked about, and I'm really trying to tie this in with everything we've talked about so far. But remember we talked about sinus tachycardia as being what? A compensatory rhythm, right? So if somebody's volume is getting down, how is the heart going to compensate? Tachycardia. They're also going to have hypotension. How does the heart compensate? Beat faster, pump more, right? Now, how can we treat some of these things? What do you think? What comes to mind?
Put in volume.
Fluids.
Med-wise.
Vasoconstrictors.
Think about your meds and what they do. You don't even have to give me a name, but what would you want to give somebody? A vasoconstrictor. All right, let's think about the vasoconstrictors we've talked about so far. Can you think of one?
Atropine.
No?
No.
No? Who said nitro? No. No, sir, you're the wrong way. That's a vasodilator. Give them nitro, you send them to the happy hunting ground. He just killed somebody. Then. Sorry. Vasopressin, yeah. Who said it over here? There you go. Vasopressin.
That's not obvious name.
It's a good potent pressor, right? Vasopressin or anything that's going to constrict. I don't know if we'll go the Levophed thing. We want something that we can give right then, push it in, instant results. And vasopressin, 40 milligrams is pretty good. You don't have to worry about the milligrams. That's what it used to be. I don't know what they did. What's what you gave the code, 40 milligrams. Vasopressin is a vasoconstrictor. It reduces portal inflow. I think you can look on page 1302. It talks a little bit about that. How to treat it. There are also other things that we can do for these things if vasopressin doesn't work, especially if we have a good rupture or dissecting area. You can do sclerotherapy, where they actually go in and sclerose that vessel, actually clot it up so that it doesn't bleed anymore. We can also do balloon tamponade. What do you think about a balloon tamponade? Yeah, it's a balloon that goes up and just presses against the esophageal walls and actually occludes it and keeps the blood from, it's kind of like putting your finger over it and holding pressure. Varicose banding, they can go in and band them off. But I'm going to tell you, that's got to be in the leaking stage. Because if they're in full-blown bleed, I'm telling you, esophageal varices, it's a gruesome death. Gruesome. I mean, they just bleed. I'm talking going through like a DIC patient, upwards of 30 units of blood. I mean, the blood they're bleeding out ain't been in their body that long to even get used to being there. Now, if we're giving vasopressin for patients with this, what do we want to have on hand? Or what do we want to know in advance? We want to have a good history, don't we? We want to have a good history. And you want to balance this with, the good versus the bad, which I've told you all time and time again about this. If they have a history of stroke, MI, they may have one. Because you're going to give them vasopressin, right? And what's vasopressin do to those vessels? Yes, it does. It doesn't just constrict the esophagus, it constricts everything, right? So if they're stroke patients, they may have another one. And these are things that need to be talked about with the patient in detail.
Could we give them could we give them a beta blocker to stop to help decrease the heart rate from the tachycardia?
You give what now?
Could we give them a beta blocker to help decrease the heart rate?
I figure at this point you're just trying to stop the bleeding. You're in the ABC thing, the airway breathing and circulation, so you're really in C mode. They can stand the tachycardia for a little while. Really, it's difficult to slow down a tachycardic patient that's compensating for something. you'll find lots of resistance with that.
Are these alcoholic patients you hear about that it's like, you'll hear the family members say that they just start bleeding out everywhere, like out of all of them?
Everywhere. Are all patients known alcoholics?
No.
All right. Yeah, we took one out of the car and they just couldn't figure out what was wrong with Daddy. They had no idea what was wrong with Daddy. And you can't imagine how insulted they were when we told them that Daddy was drunk. Bad. And apparently, looking at his labs, Daddy drank quite a bit and nobody else knew it. So he was closet alcoholic. And it was news, they still don't believe it. He had his alcohol. I mean, he was rocking near 400 on his alcohol, blood alcohol. You have to have some tolerance to be able to do that. Otherwise, you'd be dead. Which he wasn't too far from it. He came around. Some fluids, a low tube. All right. Is this going okay so far? Yes, sir?
Is the vasopressin after the hemorrhage to slow the bleeding, or is it preventative?
Both.
Both. Okay.
I mean, if you know that they have them, which you generally don't until they come in, you know, unless, I mean, think about it. Somebody that abuses alcohol daily, are they up on their health that good? No, they're at home abusing alcohol. So they're not going to the doctor and having their EGDs every year as recommended by, you know, they're not doing it. So generally they'll start spitting up some blood. And it may be a subtle leak, and then it just continues to, as the portal hypertension continues, it'll continue to dissect.
Do you have to do any kind of suctioning to get the root, like the hemorrhage?
Yeah, you'll have
filling
to
up
suction.
the-
It'll be a god awful mess in that brain by the time you're done. It'll be awful. All right, we're good? Take a break. Another hepatic problems that occur. And so we've got ascites, we've got esophageal varices. One big thing that really occurs is called hepatic encephalopathy. Now, this is a huge deal, okay? Huge deal. I will tell you that if you're familiar with encephalopathy, encephalopathy is encephalopathy. Whether it's hepatic or HIV, you know, you can have different HIV encephalopathy, you can have, I mean, there's a lot of different encephalopathies, but generally a lot of them are the same symptoms. Hepatic encephalopathy or portal systemic should make it make sense. Encephalopathy, increase in ammonia and other toxins in the blood, which can be reversed by early intervention, but sometimes don't get reversed early enough. When these ammonias and other toxins build up in their bloodstream, they cause swelling in the brain, which can cause all kinds of neurologic issues. Some signs that you will see with these patients is apathy. We know what apathy means?
Not there.
Don't do it.
Don't care. They're giving Am's broke. Sounds like a country song, doesn't it?
That is a country song.
Is it? I was gonna copyright that. Restlessness. These patients are very, very restless. They can almost become combative. They do eventually. Slow thought processes. They get very deliberate in what they do if they can focus long enough to do anything. Slurred speech. along with inappropriate speech, where they just won't make any sense anymore. Or they'll talk about different things in the wrong context. Asterixis, you know what that is? Well, they'll have this, yeah,
Flapping.
flappy fingers and wrists, especially when the arms are extended. Sometimes we call it the liver flap. There's also a test you can do for this encephalopathy patient. You can actually take a pin and lay it down on the bedside and tell the patient to try to get it. It's a very interesting deal. They don't have control well enough to, this is very difficult right here. Whereas you and I can look at the pen and we can just grab it right up and go to town with it. But no, they're having difficulty with this. Okay? Or have them write something. No, okay. Musty breath. Now look, you're not getting your nose up close and smelling, all right? But this breath is unique. We call it Fetor hepaticus. That's Latin for damn. I'm trying to liven this one up, y'all. It's not my wheelhouse. But it is. Anytime you have the Fetor hepaticus is bad. Any of that hepaticus is like, oh. But yeah. And you'll love them for it, but they'll let you know because they'll put their face right in yours. Have y'all noticed that you've been in healthcare long enough?
Oh, yeah.
That every time how about when you get down and you're trying to wrap that blood pressure cuff around and they'll always look at you and go, what is up with that? Right? So, yeah, if you have one with Fetor hepaticus do that, you will never forget it. It's well beyond tic-tacs. All right, we talked about confusion and combativeness. Hey, some of these patients can just darn near hurt you and hurt themselves. So safety issues are paramount, aren't they? We may have to restrain, keep them from hurting themselves and others. Clay-colored stool, that comes with any kind of liver problems generally. Petechiae. What are,
Like purple,
Oh.
bruises on the skin.
There, yeah, dots.
little bitty red, purplish spots that come up on the body, just kind of random, but you'll see petechiae. And I think we've posted these up, haven't we? Are they on,
No.
we sell these for, well, this one talks about cirrhosis, later clinical manifestations. And it's got the jaundice. Hey, it's one of those things like I'm asking you to do. One of the things I failed to mention a while ago was the spider angiomas. Have you ever seen those?
Don't it look like?
This is like red, flared out little vessels right there on their face. Have you seen those? Yeah. When I come back from cruises, I'm going. It's legitimate. But you can see those people like have, it's not just all drinkers, but generally drinkers, like daily drinkers. I'm not just talking about people that have a beverage, a couple of times a week. I'm talking about people that wake up, eat breakfast, crack a beer. Or they start in, they drink a fifth of whiskey a day. All right? So, I will make sure these get up on Blackboard, okay? I believe they are. I don't know why they're not showing up, but I will make sure. The other one is we've got one about hepatic encephalopathy. All right, so for hepatic encephalopathy, we have some interventions we can do for these people. We monitor their ammonia levels, don't we, closely? Who drew the ammonia? Is it the person, that's, anybody drawing ammonia lately? They still make you put it on ice before you send it to the lab? Nobody knows? Yeah, agreeing on ice? Yes. Keep it from breaking down. Seizure precautions, because seizures are a real issue for these folks. Anytime you increase the swelling of the brain, which increases ICP, seizures are an issue. Okay? And you do not want a liver patient skeezing, do you? No, you don't. Y'all all got that skeezer thing down, don't you? Yeah, that's awesome. All right. Maintain safety at all times. Decrease risk of injury to self and others. Frequent assessment of the patient. And protein restrictions. Of course, we know the byproduct of protein metabolism is ammonia, right? But does it mean that we restrict patients' protein completely? No. So what do we want to do with their protein?
Decrease it.
Well, you'll manage it by the amount of ammonia that's staying there. So if the ammonia level's high, we're going way down on the protein. But if it's at a moderate to low level, we can, they can have some protein.
Not
Okay.
sodium, just protein?
Well, yeah, you're going to keep them on a low sodium. But I'm just saying, as far as protein and the producer of ammonia. Yeah. All right, some medications for these hepatic issues. Most of these patients, I believe in your book, it talks about 20% of patients with these problems are susceptible to infection, aren't they? Bacterial infection in the guts. So we'll use Flagyl or the trauma. There you go. I need to put my glasses on to read that. There's some of these that I've always had trouble saying. This is one of them. There you go, that's Flagyl. And that's a frequent one that we use. What else do we use Flagyl for? It's a good broad spectrum, right? But no, there's like Crohn's disease. Yeah, any kind of gut bacteria issue, we use Flagyl for that one.
I had a patient that had C. diff, they were doing it.
C. diff, again, a gut bacteria, right? So gut bacteria, we use. I don't even want to try it. I'll go in my office in the quiet and try to make that strength, okay? Lactulose. What do we use lactulose for?
Laxative increase it.
Decrease ammonia absorption, right? Lactulose has a couple of ways it does it. One is that it decreases absorption, but the other is it has a little bit of a, what am I trying to say?
Laxative.
Laxative effect, okay? So it kind of makes them have bowel movements. And we want, if they're having 2 to 3 a day, that's good. That's where we kind of want them to be. But if it's getting way out of control, we need to be careful of that, right? We need to monitor their stool, their eyes and nose and everything. We also use neomycin, although your book doesn't mention neomycin that much. It more mentions, well, I looked at it. It doesn't mention neomycin, but I'm mentioning it here.
Neomycin sulfate, broad spectrum antibiotic, maybe given to active sclerosis.
Okay, so where I was looking, it wasn't mentioning. I don't know why.
13.
I just missed it? Oh, okay. All right, very good. We talked about banana bags and multivitamins replacement. We also glucose to slow protein breakdown. It's not the protein you ingest, right? It's muscle breakdown?
Yeah.
Okay. Because whenever you run out of glucose in your body, what happens to your protein?
It starts.
You start breaking down proteins, don't you?
Yeah.
Okay. We'll generally DC sedatives, analgesics, and tranquilizers. Why? For assessment of what? It's hard to assess their LOC when you're giving them tranquilizers and sedatives, right?
Does it
And
have,
if,
oh, sorry, does it have something to do with the motility also? Could decrease that?
no, it's more of assessment of LOC. Yeah, that's a good point. I guess it would affect that. Constipation would be an issue. But we're talking more about just LOC. Because if you get their ammonia under control, the return to baseline is fairly dramatic. As the ammonia goes higher, the crazier they get. And as it drops, they get to their baseline again. Okay? All right, does that make sense to everybody? I think the book read is pretty good on it. But let me just say this. I would stay within the confines of this map and your blueprint for testing purposes, because a lot of y'all tend to want to go way deep. And there's a lot of information about this stuff. Hepatitis. Still involvement with the liver, right? Over there, y'all got your hepatitis mapped out?
Hepatitis with a vowel,
Hmm?
I read hepatitis with a vowel, and so the vowel. Like A, E,
Oh,
you say it. Like there's A, B, C, D,
yes,
E.
yes. That's the one I'm on.
Which of us is on Blackboard?
All right, hepatitis is inflammation of the liver caused by a virus, bacteria, or a toxic injury. What we're going to talk about is several of them. And listen, they got hepatitis now that go way beyond D. All right? Hepatitis A. It's always my favorite. Fecal oral transmission. We've talked about McDonald's, right? Take a culture swab in there and swab the bathroom door. You know how I come out of there, don't you? Like a surgeon? I walk out and I hit the back, my back goes against the door, and I hate it for whoever's behind me. 'Cause I'm coming out of the back. Because bad news in there. Poor hygiene. Now, come on, patients have poor hygiene. Are you serious? Contaminated seafood from the people that's working that have poor hygiene, or that failed to wash their hands when they went to the restroom, or both. If you eat out a lot, you're running risk of this, right? Hepatitis A is a restaurant problem, isn't it? Sounds to me like it. Oh, and then there's intimate contact. Prevention, hand washing, this is all common sense. Proper water, proper sewage disposal, proper hygiene. proper protection. One of my favorite teaching mottos in the ER when somebody came in with an STE or something else that's contracted that way. Don't be a fool, wrap your tool. Don't be a punk, wrap your junk.
Ours is no
We can go on forever, right? Oh my goodness. All right, so it's not a chronic condition. People get better from it. I think my uncle actually got hepatitis A from oysters. There's only a certain time you're supposed to eat oysters, but I don't think that was the problem. Whoever's cracking them oysters forgot to wash their hands. All right, hepatitis B. Now this is the one that we all get vaccinated for, don't we? We're vaccinated for Hep B. And because of that reason, Hep B is not as prevalent as it used to be, right? Prevalent, it used to be prevalent. And they started vaccinating healthcare workers and really kind of stopped things somewhat. Doesn't mean it's not still out there, because it certainly is. But we all have to be Hep B. All right? So Hep B comes from blood, saliva, so this is the kissing hepatitis here. Semen? Sailors?
Thinking this.
I'm sorry. Vaginal secretions? The semen and sea women? Face matching my shirt right now. Even passes between birthing mothers and infants at birth. The only defense against Hep B is the vaccine, right? Prevention. The primary prevention is the only defense against it. Hep C. Hep C is probably more prevalent than AIDS and HIV anymore. It's way overtook it. It's spread like wildfire. Why? Where does Hep C, what population is vulnerable to Hep C? IV drug users. And you know we have an epidemic of that, don't you? You know what's making a comeback, don't you? Heroin. Heroin got such a bad rap during the late 70s, early 80s. You know, this is my time to grow up. But I mean, I graduated high school in 1985, so I remember this stuff. I was not unaware. Okay? But it got such a bad rap. But I think that people were just downright afraid to do the stuff. And then they kind of quit talking about it. Well, now we've got a whole generational shift, and this stuff's starting to come back into the country, and people didn't know. I mean, you know, nowadays your TV shows are about stuff, but back then TV shows were always centered around heroin addicts and, you know, all those cop shows, and you'd show all those heroin houses and stuff. It was bad business. Y'all's generation, crack. And, you know, meth by most, but, you know, those crack houses they used to show and all those specials they did, all that information, people got scared of it and they won't do it. Well, good God, here's an alternative, heroin. Right? So these people, in their wonderful judgment states, share needles. And that's bad business. Back in the early days of tattoo parlors, they didn't do so good a job of cleaning those needles either, so if they didn't clean them good, you got somebody came in before you and you get a tattoo, yeah, some of the people got Hep C from tattoo parlors. So there's a myriad of places, but it is transmitted by blood and sexual contact. After these lectures like this, if you're single, don't you want to, take a history on them, make them pee in a cup, do a background check on them? Or Hep C has a distinction of being a 33% chance of liver cancer developing. And it's the most common reason that we need liver transplants. There are some major stars out there that have that. Aerosmith, Steven Tyler, has Hep C. But they have the drugs to treat it, and the antivirals, and then they have the money to take care of it. Crosby, Stills, what's his name? Yeah, from Crosby, Stills, and Nash. Crosby, he's had multiple liver transplants because of it. Who?
Is that a generation gap?
Yeah, we don't know who that is.
Really?
Pamela Anderson.
Pamela
and
Anderson.
Tom
Well,
Brady.
these are the people that grew up during the heroin times, okay? So, if you want Hep C, y'all go out there and give her a whirl. But I'm telling you, this is really what's occurred, is that they shut that, it's almost like they shut that line down. We'll bring it back in 20 years and nobody remembers what kind of hell it produced to a population. And heroin, much like crack cocaine and methamphetamine, is one of those drugs that you go to a party and do it just for the fun of it, and 2 weeks later you're strung out. And you die. Because you don't ever come off of it. You never can cure that. It's bad news. Very few get off of it. Next one is E. Again, fecal oral route. It resembles A, and it's not a chronic issue. So A and E, we're not real sure, but they're pretty close to the same. And I really don't care to differentiate any further than that. Hepatitis D, only persons with Hep B are at risk for Hep D. So if you get B, you get D. The same risk as group B. Patients are likely to develop liver failure and chronic hep and cirrhosis. So it's really going to just destroy their liver. Now, this next one is called the phases of acute hepatitis. And I just want you to know that it is not in your book, but you have the deal, so it's important that you follow along with it. What else is different? Or did you just expand the process? Oh, I know why. All right, so the acute phases of hepatitis are pre-enteric, during this phase, it occurs 1 to 3 weeks before jaundice, mimics flu symptoms, abdominal pain, headaches, malaise. Sounds like flu, doesn't it? During this time, patients will have, am I going too fast?
Yeah.
Okay, sorry.
You said it happens when?
All right,
1 to 3 weeks
pre-enteric
before jaundice.
phase occurs 1 to 3 weeks before jaundice, pre-jaundice. Okay? Mimics flu symptoms, abdominal pain, headache, malaise. You'll have elevated ALT, AST. So elevated ALT, elevated AST, and increasing urine bilirubin. Which only makes sense, right? It just hasn't got to the symptomatic part yet, but it makes sense. Good. Ecteric phase may last 2 to 6 weeks. And that's where we get jaundice, bowel salts on the skin, light brown or clay-colored stools. Does this sound familiar? Dark urine, anorexia, liver tender to palpation. Sounds like liver failure to me, doesn't it? Or cirrhosis. I mean, if you have something affecting the liver, the symptoms are pretty close to the same. The only good thing about hepatitis is some of it is curable and some of it isn't. Post-icteric. Are we good now? Can I move on? Sorry, y'all, I got sick for a second. May last 2 to 12 weeks. Jaundice subsides, stools return to normal color, labs return to normal, party's over. Everything gets better. Labs return to normal. Labs may be or may increase if this is the case. So one of the things that we do for these patients during these times is we put them on. Here comes the interventions. Next box down. And I'll go back to the point on post-icteric in just a second. But I was going to finish a thought there, but I think I need to talk about interventions first. Bed rest. Bed rest is critical for this, right? Bed rest is very, very important. Nutritional support. No alcohol during hepatitis outbreaks. It's a real bummer. You got a lot of things like that. If they're drunk. If they're alcoholics, yes. But now listen, you don't have to be an alcoholic to get hepatitis. You can go down to Taco Bell.
I don't even eat.
Or Burger King, or Popeyes, or any of those places and get this. And let's not just hit the cheap chain. I mean, you can go up, look at Chipotle. That's Chipotle or whatever it is. That was like a woman magnet. My wife liked to eat there 5 times a week. She had to eat there. She took me there. I thought it was a bunch of crap myself.
Yeah.
And it was $5.
Yeah.
And then what did they have? E. coli. Where's E. coli come from? The bowels. So from the bowels of somewhere, Chipotle comes out and has bad stuff. Jack in the Box. We don't have any around here, but yeah, they killed some people. That was some bad stuff. So it's just not alcoholics that have this problem. Now cirrhosis, yeah, that's by majority. So bed rest is important. Nutritional support, no alcohol. Treatment of symptoms, and that comes back to what we were talking about a while ago earlier with the cirrhosis patient. Treatment of those skin rashes, the itching.
What do you do about that? Because you said you can't do lotion.
It's just, is it washing like mild soaps and
Cold water.
cool water, not hot?
It's a box.
It's cool water, not hot, and you don't use lotions. And the other thing is you don't have them wear dark clothes either, right?
The dyes.
Just like babies, right?
Yeah.
Tell them to go for a walk in the sunlight. Well. So treatment of pain, pruritus, and jaundice. Now, what I was talking about, what I kind of stumbled around on awkwardly in the post-icteric phase is that it may last 2 to 12 weeks. And jaundice subsides, stools return to normal color. It's kind of like the diuretic phase and the oliguric phase in renal failure. Labs may return to normal levels, but if labs start to increase again, what happens to the patient? Go back on bed rest. Does that make sense? They're not quite done yet.
So they can just relapse and just.
Yeah, it can get worse again, so we monitor the patients, and if they start getting better, labs start improving, and we take them off their bed rest and they start going the other way again, we put them back on bed rest until they get better, until they get completely healed. So it's important to monitor that, okay? I think that's really about all about hepatitis. Any questions? All right, let's move on to pancreatitis. I think we can get pancreatitis done. I don't know. Y'all need a break? Go pee, hurry, come back. And then I think 30 minutes will be done.
Thanks for the,
Anybody else?
yeah, I appreciate it.
Might as well go.
Thank you. I know.
All right, here we go. So, Billy Rubin, total Billy
Oh, he's right.
is, if you laugh at me, I'll stop. That's deciliter. You can go ahead and write down the pancreatitis level too. It's got 21 minutes, 21 seconds. It gives you a 100-second countdown on that one that is suspense. Here we go. Is it really? Hey, there we go. All right, here we go.
Oh,
Hey,
yeah.
the first time I did
That was smooth.
And
I ain't supposed to.
can y'all see that now? I'll give you a few minutes to copy that down. Save me from writing on the board. Don't take pictures because I'll be in the picture. So what happens if you don't take a good picture? Yes?
Does it say 8 to 20 or 8 to 30?
I can't.
8 to 20. ALT, 8 to 20.
What? That says milligrams per deciliter. Oh, okay. What does yours say here? It may be milligrams, I don't know. I promise you that we're not going to hang you with micrograms versus milligrams. And if we do, I'll personally want to get that question. We need numbers here, don't we?
Yes.
And we used to not even put those lab values on the end of it, or the actual differentiate. We'd say, you know, we want an AST to be between 5 and 40. And that worked for us, but they since wanted us to start putting the labels on them, so. Has everybody got that? You got the amylase and lipase, because that's what we're fixing to start talking about. Amylase, lipase. Good Lord, look at that glass.
We did it.
I'm sitting here running my gap. Are we good now? Now turn this off.
Good job, Blake.
Going once, going twice. Out of here. Okay. Any other questions or things that we need for liver that I may or may not have covered? If you do come up with them, it'll be a good time tomorrow to talk about it. And what our plan tomorrow is to have come in, we'll do like a short review, and then like we did the other day, we'll send you out. We'll walk around, we'll answer questions. You can go to your study groups. You can rejoin your friends next door and do whatever you do. But we'll be around to answer questions, okay? Till, I don't know, 2-ish. Then I'll be making my escape plan. It's always good to have an exit strategy on Friday. All right, so pancreatitis, inflammation of the pancreas, which can be mild or it can be life-threatening.
Susan, come on. How is he in here?
Hey, lucky you didn't get in
I
here.
don't know. Cocker poked his little head in
I
here.
assure you, he was left with a little less glue. All right, inflammation of the pancreas, which can be mild or life-threatening. Y'all, this is, pancreatitis is probably, and y'all had this in 1505, right? Okay, so y'all had, this is more the acute aspects of it, or the seriousness of it, and the life-threatening part of it, because it could be serious to patients. And they can die from it. About a 10 to 15% mortality rate on this. Leads to massive hypotension, fluid and electrolyte disturbances, and shock. So these patients can go into hypovolemic shock on these really bad. They can develop bleeds. We'll talk about, we'll go to the left of your box there, and we'll talk about acute first. And just because somebody has acute pancreatitis doesn't mean they're on their road to Crohn'sville, okay? Doesn't mean they're going to have it forever eventually. Acute pancreatitis may have a duct that becomes obstructed, enzymes back up to the pancreas, leading to inflammation and essentially autodigestion. Does that make sense? Duct becomes obstructed, enzymes back up into the pancreas, leading to inflammation and autodigestion.
Duct obstruction enzymes back up into the pancreas and then leads to autodigestion.
All right, so you'll have an increase of amylase, you'll have an increase of lipase. In all of these, an increase in bilirubin. All of these are involved in digestion. And when they can't exit the pancreas, that's when the autodigestion occurs. Does that make sense? We develop these for digestion, but when they can't get out, well, then they just start digesting wherever they're at. Chronic occurs when 80% or 90% of the pancreas is inflamed. And one of the leading causes of chronic pancreatitis is what?
Alcohol.
Alcohol. If you see somebody in the ER come in with pancreatitis quite often, you can pretty much, I don't care what they say, you can pretty much put your finger on it, that they're alcoholic. Chronic pancreatitis is progressive inflammatory disorder with destruction of the pancreas. Again, like cirrhosis, cells are replaced with fibrinous tissue. Therefore, it becomes less pliable, and pressure increases. I'll read that again in just a minute. Mechanical obstruction occurs and destruction of cells occurs, similar to cirrhosis of the liver. Basically what you have happening is you have cell destruction in the pancreas replaced by scar tissue. Is that easier? Sometimes we get a little worried. But no matter what, whether it's chronic or acute, just like renal failure is what?
Renal failure.
So if you have acute renal failure, it gets better. If you have chronic, it doesn't. If you have acute pancreatitis, it gets better. If you have chronic, it doesn't. But the signs and symptoms are the same, right? What do you think they are?
Pain.
Pain. Let's talk about pain for just a second. Excruciating pain. Crawled up, balled up in a fetal position, pain. These people aren't putting on, they're paining. They're hurting. It's very painful. Severe abdominal cramping. Nausea and vomiting that's irretractable. What does that mean?
Can't stop.
That means we can give all the Phenerin or all the Zofran, I almost said Zoloft, all the Zofran that we want, but we're not going to stop it. How do we stop their vomiting? NG tubes and gut rest, don't we? MPO, no intake, and an NG tube. Go back under your abdominal pain and put rigid, tender abdomen. They'll have right-sided guarding, or not right-sided, but just abdominal guarding and potential for a rigid tender abdomen. Good God Almighty! That was a tongue accident right there. Just run right off the road. All right, we need to start over here. Abdominal pain to the point of incapacitating. You'll have abdominal guarding with potential for rigid and tender to palpation. That means you can't even touch your stomach, and they'll let you know. excruciating disorder. As well as pancreatic cancers. Probably, you've heard this. It's one of the worst deaths, one of the worst cancers to get if there's such a thing. But it's deadly, and it's painful, and it's awful.
Isn't it like the shortest, the one that you can die from the quickest?
Not necessarily, it depends on if it's small cell or large cell. Large cell is slow growing, small cell kill you in 3 months
Yeah.
or
Yeah.
less.
My mom had pancreatic cancer. She died in like 1 month.
It's terrible, and it's, I had a coworker that her father was just fine. Went to the doctor one day and was having just a few abdominal problems, and they diagnosed him. He had small cell and went rather quickly. You know, it's sad, and it's a terrible disease. Although I think quickly, in that sense, is maybe. I mean, it's a lot of suffering that goes on with that. Intense weight loss, nausea, vomiting, which leads to dehydration. So you need to be sure that you know hypovolemic or dehydration signs and symptoms. So you go again with your tachycardias and your hypotension, right? Dizziness, orthostatic hypotension. Sometimes when the body is, dehydrated or in a decreased volume state, the heart can catch up to itself and maintain that blood pressure at a level it likes. But when you stand right up, it doesn't have enough volume to keep that pressure up, and it has to catch up by compensating faster beating or some constriction. Also have dyspnea, hypoxia, respiratory distress. All these are possible. Abnormal ABGs. So, with the pain, what do you generally do with your breathing?
Shallow.
Yeah, so they're shallow and they're breathing rapidly, aren't they? Because they're hurting so bad. So they run the risk of going into respiratory alkalosis, don't they? But here's the twist. They vomit so much, what else are they at risk for?
Metabolic alkalosis.
Metabolic alkalosis, aren't they? Good. Thanks, students. They can have generalized jaundice, confusion, and fever. Ecchymosis in the flank and umbilical areas. And that's a big deal. That's a big sign right there that ecchymosis shows up. Do we know what ecchymosis is?
It's crazy.
Bruising. Stools. Now we always have to talk about stools, don't we? Bulky and foul smelling. Fouler than normal, how about that? Straturia. Yeah, it's a foulness you've never encountered before. It's foul times 2.
I think that's spelled right, but
Normal fat content in your stools is usually around 20%. These are around 50 to 90%. So, big time. Fatty, stanky stools. Tachycardia and decreased blood pressure related to hypovolemia, we talked about that. And it's related to possible hemorrhages, because if you're having that ecchymosis, that means that you're hemorrhaging, right? Yeah, they can auto-digest and traumatize to the point where the pancreas starts to bleed. And they can have pretty bad let's talk about some labs. The first lab and diagnostic procedure is to find out what level of pain they have. Most of them are 10, some are 15, on a scale of 1 to 10. If you ever take care of a pancreatitis patient, you'll know them, you'll never forget them. Anybody ever taken care of a patient with gastroparesis? You've never heard such wretched vomiting in your entire life. And it's relentless. It just goes on and on and on. Look, if I vomit twice, I'm uncomfortable with it, I'm done. I just don't like to, and I don't very often. But, yeah, to do it just for an hours at a time, it's constantly. It's just awful. Never heard such. Generally with these patients, serum amylase will increase within 12 to 24 hours and generally will stay elevated for 2 to 3 days. So amylase is going to be up. But the best indicator for pancreatitis is lipase. It takes it a little bit longer to indicate or increase, but it'll stay elevated throughout the event. So you can draw an amylase. If the amylase is starting to inch up, you know that there's something going on. Lipase will confirm it. Does that make sense? White blood cell count, usually around 16,000 or greater. But of course, anytime we have stress, white blood cell counts go up, don't they? Or inflammation. Any kind of inflammatory infection or stressing kind of process goes on. You know you can vomit and your white blood cell count goes up, right? A good old virus, stomach virus, that 24-hour variety will kick your white blood cell count up because you're vomiting. Now, that's not a chemistry. Maybe 1,000 or 2. Glucose will go spiking. There seems to be a little bit of a tie-in with diabetics and pancreatitis too. Increased bilirubin and potentially a decreased H&H. So I need to monitor those closely. Need to monitor their albumin. Am I going at a good enough pace? Y'all keeping up?
What did you say on the H&H increase?
Increase.
Decrease. Monitor decreased albumin. It's okay. Monitor potassium levels. What do you think with potassium? What do you worry about when you're vomiting and you're losing all your water out of your bloodstream?
Low
What
potassium,
potassium,
have arrhythmias.
hemoconcentration, aren't you? When you hemoconcentrate something, what happens to the electrolytes? You ever seen a dehydrated patient's chemistry? Oh, they'll have a 6.3 potassium. Their sodium will be 155. These are just arbitrary numbers. But it's because they're dehydrated. Think about Campbell's soup. What do you got to do to it? Add a can of water, right? If you eat it just straight out of the can, it's too.
So,
Yes. So you got to dilute it. Well, when you hemoconcentrate things, every one of your indicators will be elevated. And that's one of the ways you know. When you pull the lab up, everything is this way. You're looking at it going, what the heck is going on here? Sodium's up, potassium's up, everything's up. And then you start pouring fluids to them. By the way, is what we will do for pancreatitis patients. We'll start giving them fluids once you start pouring the fluids to them, everything will level off and then start to drop. So these are falsely high levels. That makes sense to you? Any questions about labs and all that good stuff? So what do we want to do for these patients? What is the meat of the matter? What is the nursing care thing? What's our priority? Pain control. How do we control their pain? Narcotics. What kind of narcotics? You think we can just give them any kind? No Demerol. Why no Demerol? There's a little thing, the sphincter of Odin, yes. Now, there's some research that says that may or may not be true, but we're going to go with it. I think it is. Drugs of choice for pain control, you might want to write this one down. Morphine, hydromorphone, or Dilaudid. People ask for it by name. They love the Dilaudid. I like the Dilaudid. You don't have to sit there that long. You just give, they're like. Whereas Demerol or morphine, morphine, man, you have to go get more and go get more. And you'll pull 10 out, give it to them, didn't do crap. You'll pull 10 more out. What are you worried about with morphine?
Respiratory
Any of that stuff, right? Respiratory depression. What does morphine do? And this is not testable stuff. This is just classroom, clinical in the classroom. Y'all, how many have y'all given much morphine in this room? What have you noticed about it?
It doesn't work very long at all.
It doesn't have, especially if you give it IV, right? Anything IV doesn't really hang in there. Why IM is better for longer term pain control. But the really cool thing that's not cool about morphine is that it has a creep value to it. Whereas Demerol you can give to somebody and you just almost get instantaneous pain relief. Same thing with Dilaudid. Morphine, on the other hand, they will start feeling it, but it's kind of a weirdness that just kind of starts at the toes and works upwards. And if you're not careful, if you're pushing it too rapidly, you'll overload them, is what I'm trying to say. With morphine, my trade was always to push a little and just sit and hang out for a minute and see how they respond to it. And push a little more, but give your pushes, in between your pushes, give it time to take effect so that you don't go too far too fast. It'll load on you is what I'm trying to say. So, first time you ever go in and sit down and push morphine, if you push it rapidly, you'll see what I'm talking about. It's not cool. All right, so use morphine or hydromorphone. Fentanyl's also a good one. Sometimes we put them on PCAs. Something we talked about in class or in clinical yesterday I need to talk to you about is PCAs. Can we push them?
No.
It's not nurse controlled, is it? It's patient controlled. We don't have an order for that, do we? How many have you ever seen a nurse push it? Let me push it. You can put it in their hand, but they actually have to have their thumb on it and push it. Okay? Doesn't mean you put it in their hand, put their thumb on the top of it, and then stomp their thumb. All right? Medical management. Nutrition. These patients go MPO immediately, don't they? Yes, they do. We may have to do J-tube feedings. With the exception if an ileus is present. If an ileus is present, we're not going to use that. They'll get an NG tube. They may get enteral feedings. We prefer that over TPN. Less glucose problems occur. Treat knowledge involvement. We're going to use the NG tube to treat that, aren't we? Yes. We use antiemetics too, but when those don't work, we have to go with the NG2. It may actually, to stop the nausea, we may use a combination of the two. Restoration of circulating volume. That's a fancy way of giving fluids without overloading them. We'll go with the restoration of circulating volume. Bed rest. Big time. Use a lot of H2 agonists or antagonists such as Zantac or Prilosec if they're able to take PO meds. Otherwise, we may have to use something IV, right? What's the only H2 you can give IV?
Protonics.
What's EPI?
Commodity.
Famotidine. Ha! I can say that one.
It's all to let the pancreas rest. Famotidine.
I never could say that. There's a couple more that I just can't get, it doesn't come out. All right. Electrolyte replacement. Antibiotics. Negative antibiotics. Eliminate caffeine and alcohol. So when you're looking at pancreatitis, think about your patient. This goes with the liver, the cirrhosis, hepatitis, pancreatitis. Look at your patient. Draw your patient. How are you going to walk in? What's this patient going to present like? What are your priorities? What are your interventions? What are your desired outcomes? And then also, how would you teach a patient from getting back to where they are now? How would you teach prevention? Or home care? Or either that matter. Nursing interventions, control pain. Control pain. Sudden and severe pain can mean rupture or hemorrhage. So if we got sudden severe pain, we need to investigate more than just killing the pain, okay? Most of the time they find comfort in a fetal position or sidelining. Monitor eyes and nose and daily weights. Now, if they're having a lot of vomiting, then you need to maintain oral care, don't you? What's all that stomach acid do to the enamel of your teeth? Right? One of the big ways you can tell somebody has bulimia is their enamel in their teeth, right? Skin integrity. They may have drains. Watch your nutritional status, and it could put them at risk for pressure ulcers. Being wanting to lie in one constant position. And just in your book, look over the interventions to promote health of patients with pancreatitis and reduction of risk factors. And I think that's all I've got for pancreatitis. Y'all got any questions?
What did you say again for the Jason?
Yeah, if there's not an ileus. But these patients are real susceptible to developing an ileus.
You say you would put in if they didn't have it?
They may have one, and that's all you need to know. Unless you plan on going to med school. Because that's going to be a doctor call, not us. This is just stuff you need to be prepared for. If you have no further questions, and you are a BA student, you may leave. And we'll see you tomorrow, right? don't care what they class or school thinks to do, I corrected them.
Monitor for increased glucose, I think.
Lawrence,
Where was that?
you're always where I am. Yeah.
Oh, TPN causes less glucose.
Ah. So I gotta try to be better this time on 60.
I had so many notes and stuff.
Benton,
You don't have to write home for it.
Benton's like, we gotta get
No, it's gonna be 8.
6 months to see him redo it, going, and
I had to get this one.
once a year after that. So,